Now, today we are going to talk about HMG-CoA reductase inhibitors. These HMG-CoA reductase inhibitors, they are also called as the statins. Statins or HMG-CoA reductase inhibitors. We have seen in the pathophysiology that HMG-CoA is a rate controlling enzyme or rate limiting step in the biosynthesis of cholesterol. It is a rate limiting enzyme in the biosynthesis of cholesterol. Now the first drug in that category is the lovastatin and its congeners like rosuvastatin, atorvastatin, pitavastatin, they are structurally similar to the enzyme HMG-CoA. Lovastatin and its congener, they are structurally similar to the HMG-CoA and therefore they are competitive inhibitors of the enzyme HMG-CoA, and that's why they are also called as HMG-CoA reductase inhibitors. Statins are also called as HMG-CoA reductase inhibitors, and they are the competitive inhibitors because they are structurally similar to each other. Why they are competitive? Because there is a structural resemblance. So synthesis of cholesterol in the liver is reduced. Synthesis of cholesterol in the liver is reduced. As you can see, acetyl-CoA is converted into mevalonic acid. HMG-CoA is converted into, acetyl-CoA is converted into mevalonic acid with the help of HMG-CoA reductase. So this is the rate limiting enzyme. If we inhibit this HMG-CoA, the synthesis of cholesterol in the liver is reduced. Okay. Now, if there is a decrease in the synthesis of cholesterol, so liver require cholesterol for the synthesis of bile acid and steroid hormones. There is a liver requires cholesterol for what purpose? For the bile acid and for the steroid hormone, for the synthesis of bile acid and for the steroid hormones. It respond. How it responds now? It responds by increasing the uptake of LDL from the plasma. Now what liver do for the cholesterol synthesis? It increases the uptake of LDL. It increases the uptake of LDL from the plasma, and this is done by increasing the LDL receptors on the hepatic surface. On the hepatic surface, there is an increase in the LDL receptors. So there is increase in the expression of the hepatic LDL receptor, so that more LDL is taken up from the circulation. More LDL is taken up for the circulation. As a result, plasma level of LDL cholesterol and triglyceride fall. Right? This is the most powerful action of the statin. Statins are most powerful LDL lowering agent, which is the bad cholesterol, which is a lethal cholesterol. Okay? And one more effect, the concentration of HDL cholesterol increases by 10%. The concentration of HDL increases by 10%. Now, the most potent statin is the pitavastatin. The most potent one is the pitavastatin, which is followed by the rosuvastatin, and these are the fluvastatin and lovastatin are the least potent one. These are the important points in the statins. Now, activity of HMG-CoA reductase is maximum at night. The most important question that everyone asks, why they are preferred at night? Because the activity of the HMG-CoA reductase is maximum at the night. So these drugs are administered in the night. They are preferred at the bedtime after meal, because the cholesterol synthesis occurs mostly in the night time. The activity of this enzyme HMG-CoA reductase is maximum at night. So we will prefer this drug at night time. But nowadays newer drugs are there, like rosuvastatin, half-life is 19 hours, atorvastatin 14 hours. These are the longer acting drugs. So these drugs can be administered at any time of the day. Because of longer duration of action, these drugs can be preferred at any time of the day, but still physicians prefer this drug at the bedtime after meal because the activity of this enzyme is maximum at the night. So cholesterol synthesis occurs mostly at the night. So this is the mechanism of action. This is the liver, as you can see. When it inhibits the enzyme HMG-CoA reductase, when this statin inhibits the enzyme HMG-CoA reductase, so what will happen? Cholesterol synthesis in the liver decreases. In response to that, statins inhibit the formation of cholesterol, so cholesterol level in the plasma decreases. In response to that, what will liver do? There is a compensatory increase in the number of LDL receptor on the surface of liver. What liver do? There is a compensatory increase in the LDL receptors on the hepatic surface or in the liver surface. Then what is the third thing? Uptake of cholesterol from the blood, uptake of LDL cholesterol from the blood, so that level of LDL will decrease. It's the most powerful LDL reducing agent, and it increases HDL by 10%. It increases HDL by 10%. Means from the cell, this LDL is going to the liver. From the vessel, LDL is going to the liver. Okay. Now, this is the mechanism of action in the flow chart. Statins. What statins are doing? They are competitively inhibiting the enzyme. Which enzyme? HMG-CoA reductase. Now, because of that, there is a decrease in the cholesterol synthesis. If it decreases cholesterol synthesis, that means it decreases LDL, it decreases triglyceride, and it increases HDL by 10%. Okay, by decreasing cholesterol synthesis. Apart from that, it increases the expression of LDL receptors on the hepatic surface. More LDL binds and it is taken up by the liver. So there is a decrease in the LDL level. So this is the mechanism of action of statins. Now what are the pleiotropic effects? Other effects of statins, pleiotropic effects of statins. It inhibits the proliferation of arterial smooth muscles. What does it do? It inhibits the proliferation of arterial smooth muscles. Anti-inflammatory action means it reduces inflammation, it reduces platelet aggregation. They have antithrombotic and immunosuppressant effect. These are the pleiotropic effects of statins. Pleiotropic means they decrease the platelet aggregation, there is a immunosuppression, decrease inflammation, and decrease in the arterial smooth muscle proliferation. Now pharmacokinetic effects of the statins. All statins, they are absorbed orally. All statins are absorbed orally. Maximum fluvastatin, they are administered orally, and maximum absorption is seen with the fluvastatin. Food increases absorption of all drugs. That's why it is taken up. It is taken after meal at the bedtime. Food increases absorption except pravastatin. Lovastatin and simvastatin undergo extensive first pass and they are administered as a prodrug. They are administered as a prodrug because they undergo extensive first pass metabolism. Then which is the longest acting drug? Rosuvastatin is the longest acting drug. Half-life is 19 hours. So you can give at any time of the day. Okay, not necessarily you can give at the bedtime, you can give at any time because the longest acting drug. Pitavastatin is the most potent drug. Pitavastatin is the most potent drug. Now, which are the active drugs? Active drugs, these are the pravastatin, fluvastatin, atorvastatin, rosuvastatin. They are administered as an active drug. And all drugs except pravastatin, they are metabolized extensively by the hepatic macrosomal enzyme. All drugs except pravastatin, they are metabolized by hepatic macrosomal enzyme. So there is a chance of drug interactions. Pravastatin, now this pravastatin is metabolized by the sulfation, which is a non-microsomal. So there is a less chances of drug interaction with the pravastatin. Now what are the adverse effects? Adverse effects of statins is very important. Adverse effects of statins: GI disturbances. It is very common. GI disturbances, nausea, vomiting, diarrhea is very common with the statins. Nausea, vomiting, anorexia, abdominal disturbances, flatulence. Then major adverse effects is the myopathy. Myopathy and hepatotoxicity. Myopathy means there is a muscle weakness, muscle soreness. Sometimes there is a rhabdomyolysis in severe cases. And these chances of myopathy increases if these are co-administered with the fibrates, maximum with the gemfibrozil or niacin, vitamin B3 or niacin. There is an increase of chances of myopathy when it is co-administered with the drugs like fibrates or niacin. Myopathy can proceed to rhabdomyolysis, and there is a end result is the renal shutdown. There is a kidney failure if there is a rhabdomyolysis. All statins can cause myopathy. Myositis means myalgia and weakness. There is a muscle weakness and there is a muscle inflammation, muscle soreness, muscle weakness, and there is a, in severe cases, there is a rhabdomyolysis. Rhabdomyolysis means there is a lysis of the muscle fiber. If there is a lysis of the muscle fiber, so it will, that myoglobins or that muscle fiber will go to the kidney and there is a chance of renal shutdown. Creatine kinase activity may be raised. In patients with inherited genetic variation, statin can induce severe myopathy and rhabdomyolysis. In patients with inherited genetic variation, statin can induce severe myopathy and rhabdomyolysis. Now, concurrent use of any other drug that also cause myopathy, including fibrates, like fibrates, niacin, amiodarone, verapamil, should be avoided. These are the drugs you should avoid with the statins because there is a chance of myopathy. Statins are contraindicated in pregnancy because safety is not proven. Safety is not proven in pregnancy and lactation. Now the few things important about pravastatin we'll see. Pravastatin is the drug with minimum drug interaction because it is metabolized by a non-microsomal enzyme. There is a minimum food interaction because food increases absorption of all statin except pravastatin. There is a minimum risk of myopathy, that is the important thing. Minimum CNS penetration, and it will decrease the fibrinogen level. These are the important thing about